To present Dr. Biykem Bozkurt, who is the Mary and Gordon Kane Professor at Baylor and also Chair of Medicine at the Baylor VA Hospital, and a dear colleague who's been in our field, including so many of us in so many ways. Dr. Bozkurt is going to talk about something that I think I got excited hearing the topic even, and then I got more excited hearing that you're going to present. SCAI classification of shock, what is missing?
Okay, to this audience, this title now is becoming repetitious, right? So we have a consensus. We have a consensus that our current, probably, strategy needs further refinement. So though the revision just got published a month and a half ago, we're ready for the next iteration, okay? So we have the consensus, all of the experts agree, and even David agrees. So I think we're on a roll to go to the next stage. And I'm going to try to formulate, and very humbly, because I'm a heart failure doc, I'm not an interventionalist, but I will humbly come up with some perhaps strategies that I will try to suggest on our journey. So these are my disclosures. So the first question I have is, why did we embark on this journey? And I remember David's presentation. The first conceptualization was we wanted to standardize our terminology so that we knew when we said apples and oranges, everybody understood each other. Now the question is whether whatever we said was going to be incremental to what the clinical acumen already said. So reclassification. Now I'm just going to pause there. I want you to think about it, because when you know that somebody is crashing and burning, E, everybody knows, right? Everybody knows A, everybody potentially knows B, the C is a mixed bag, and D is, we already recognize worsening. Worsening we know. So the second question is whether we're going to do something with that terminology, whether that's going to be actionable. So reclassification analysis to your clinical acumen, and whether it's going to be actionable, it's going to force you to do something than what you wanted to do before. That's what I believe a reclassification may need to do. So I'm going to try to identify 6 limitations. My plea to the experts is incorporate these 6 into maybe a scoring system in a practical, simple manner that will provide the recipe to the clinician to what to do on top of what they would have done, and not measuring what they already did. So the concept of outcomes could not be in the score system itself. We all get that. Once you put the devices and everything, that's already in the scoring system. So let's go over this. So currently, C definition on the old version was confusing. We recognize that. It's wide. On the columns on the right side, you could measure lactate. You could be doing a lot of interventions. And now let's see whether the current spectrum allows us to identify the apples and the oranges as they envision it to be. It was widely adopted, but a lot of colleagues over here, when they tried to do retrospective, or one of these was prospective, they use different variables because the armamentarium of how to define the apples and oranges vary, right? We know this. So first part is we need to standardize this. We need to standardize which of these variables we need in an incremental manner to further change the idea. And I know lactate comes as a concept, but we also recognize that across the board, you've seen this slide many times, that resulted the different epidemiology of the apples and oranges. And people try to simplify this because it's complex, right? Because that large chart was not very simple. People try to simplify it. And the Thayer paper that you've seen 100 times so far actually measured the outcome more than one inotropic repressor or devices. But I see that as you need to know it before that. You need to know it before that, and you need to incorporate it in your scoring system to get there. So It didn't result in standardization. I know it prognosticated, David. I truly do know that. But if you look at the apples and oranges and how they were counted, they're all over the place. We get that. Even for E, which was quite apparent to all of us, we all recognize the crashing, burning patient. If you look at the reds, of course, these are different cohorts, but still, even the prognostication, which I'm going to come to in a minute, were not. That's that slide. So if you were to focus on C, mortality, yes, the trajectory is definitely associated with mortality, but did we not know that before? Normal blood pressure versus you're dying, that your prognosis is worse? We knew that before, so the trajectory association with prognosis is not a surprise and should not be the validation. The validation is not the trajectory of A through E is bad. We know that it is bad, but if you look at the yellows, the C's, and look at the mortality ranges, 10 to 55%, that tells me that the standardization of recognition of phenotypes, for us to say apples and oranges, is not there. So in essence, the classification didn't allow us to recognize the phenotypes that we're seeking, and is not allowing us to be actionable. And there is some attempts. I know the cardiogenic shock working group is trying to create this algorithmic scoring system with their, okay, if this, then you call this C. If this, you're calling D. That recipe varies. But first, we need to decide which one of these recipes is making a difference between that transition from B to C and within C. And guess what? There are many risk modifiers which the new revised classification identifies. I mean, you know this, the age, the hemodynamics, the RV, right? Why not give them a score? Why not give these things that we know that are bad perhaps a score? And also, how much the metabolic derangement, and I know we call it cardiohepatic versus, cardiorenal. If you have 4 organs out, it's worse, right? We know that. And the other concept is the etiology. Etiology, some of these are reversible, some of these are not. That matters as to where we're going to go. And this part, I don't think is addressed anywhere. And I am looking for perhaps, Biswajit, I'm calling out to you guys, looking at this as a potential incorporation of think of it as a scoring system or an algorithm, put that there. MI reversibility versus heart failure. And I know in the shock trials, the MI shock mortality rates were higher. I truly disagree with that. If you were to really incorporate the stage D patients for heart failure or C for you can see that a variety of our patients actually have a very markedly high mortality. But if it's myocarditis, whether it's PE and whether it is RV failure, these will matter. And thus, we need to incorporate it in a new concept. The magnitude of end organ damage, we touch on these phenotypes, and I think this was very nicely formulated in a simplistic manner through AI. But I'm looking for even a little bit more than this. I mean, I trust AI, but not that much. I still trust the clinical gestalt. We all know that when the kidney is out plus the liver is out and your coagulation is gone, that is very bad. So how to put these in some kind of an incremental quantification? I fully agree that the liver is worse than the kidney in this setting, but sometimes it's not. Sometimes I do know that the cases that we've seen, and this incremental, so it's not prognostication we're looking for. We already know the prognosis when things are crashing and burning or going in the wrong direction. So going from BC to DE, we know it's already bad. I just need a threshold for escalation and referral. And that's acknowledged in the revised formulation, but not incorporated in the staging, neither in a scaling. So incorporate these. If we were to come up with an algorithm or a scoring system with these into maybe a score, that tells me what to do in the shades. I know you guys added the shades, which is good, but I need to know within C whether I'm going at the bottom or I'm going in the wrong trajectory. And Dan's question is, within an hour, or how often should I be doing this? Those are the things I think the community needs, and the dynamic changes matter probably the most. And thus, the reversibility of the cause, the dynamic changes, if you add that to a scoring system, make it simple, don't make it 50 different variables. And I know that in the new document, this deterioration was acknowledged, but not incorporated in the staging. So in essence, I'm going to just skip to my conclusion, is do the stages help with reclassification? I would hope that we would do that study on top of the clinical acumen. Or do they actually make us manage patients differently? And that, I think, is a critical question. And maybe we need to determine the threshold of when to escalate and come up with a predictive model when we're in complacency thinking things are okay, maybe early C, or maybe even B, to make me act earlier than what I would have when things are crashing and burning. Everybody recognizes deterioration. So I don't think we have any controversy there. So I think we have a consensus, and I don't think we need to belabor the point. The issue is, how do we go forward with a new conceptualization? So those of you who are already working on this ROM, I would urge us to make it actionable, not just a prognosticator, and make it clear on the thresholds where the clinicians are uncertain. And maybe we need to then look at our armamentarium, and this is critical, of implementations in a trial design, how we will unite uniformly across the spectrum of heart failure versus AMI versus others. That care, I think, is a large care model. So we will be saying when this advanced or refer to an advanced care model, which I had identified before. So thank you for your attention.
Biykem, thank you so much. I was just going to suggest that David and Steve, you need a really incredible medical illustrator after this talk to incorporate these models. Nir, Dr. Riel, any question? Panel.
I have to say, first of all, we'll go first to the panel because I think that there are a lot of questions. Because Biykem just said, don't jump so happy from 2009 to the other classification. We have a lot of room to go. So maybe we'll go one by one. What do you think about the classification? Do we need to change it so fast, or we need to accumulate more data?
Well, we just finished. It's not that simple to get 8 different societies to agree. So, I think what we tried to do in this document was to reflect a lot of the things that you're talking about, and obviously they're true. But we've come a long ways from NCDR, where there was one box that said cardiogenic shock.
Yes.
And so, and one of the point was, and I think the reason why the stimulated looking now is because we had the validation studies. And so there's a lot of information in those, as well as we have a lot better well-defined registries that have taught us a lot. So both NCSI and the Cardiogenic Shock Working Group, plus a number of different large registries. So we were able to put more definition in terms of lactate, in terms of right heart cath, and the etiologies clearly make a big difference, right? And response to therapies are. So I think personally, I love David, and I would almost never disagree with David, but I think it's important as we go forward in trial design to actually use it in how we randomize people. And then the biggest thing, when you talked about the variability across the different validations, most of that variability comes the presence or absence of cardiac arrest. And so, for instance, the PREAK trial was all cardiac arrest patients, and that's where you saw the worst outcome. And so I think that's, it's so funny because Mike will remember this. When we tried to publish our data from the Minneapolis Heart Institute STEMI registry, and we showed that if you just had cardiac arrest, your mortality is about 20, in-hospital mortality is about 20%. If you just had cardiogenic shock, it's about 25%. Everyone's like, no way, I can't believe that. But then if you had both, it was 45 or 50%. Now, of course, it's been reproduced 100 times. And so the importance of the interaction between cardiogenic shock and cardiac arrest is critically important. And that's what a lot of the variability across the validations reflect. But clearly there's a lot of other things, age, etiology, etc. I think that was encouraging is, despite multiple different patient populations, it was still predictive.
But can I just challenge, because, you know, she just presented, and again, focusing not so much on prediction,
Yeah.
but going back, utility. What would you say you would want to focus on in the second or third iteration now that would give you a utility function? Because in terms of eCPR, we all knew that, but I'm glad that that fell out as far as the phenotype contaminating that data. But you're still gonna, I mean, we have a mechanism by which to decide what therapy for eCPR, which is you're gonna probably do ECMO for the majority of patients, unless it's a very limited eCPR. My question goes back to what Biykem said, which is utility. How would you revise so that you can really have, again, unanswered questions, and this is a guide map, a guide, not a perfect guide, but a guide for clinicians?
So two questions. First, 2 points. So first, we published a paper last year where we actually looked at the 16 trials that have been randomized and what people aren't keeping track of. Mm-hmm. So did you know in all the randomized trials, not a single time did someone record GCS score? Not once.
That's interesting.
And you know, the use of or not use of hypothermia was present less than 50% of the time. Lactates were only present about 60% of the time. So the point is, going forward, all of those things should be included in a randomized trial. And I personally think, you know, in our CIRC paper last year, the invasive manner, that slide's been showed several times today. I think that already, I think if you're an extremist, I think, you know, ECMO Impel is not going to work, boom pump's not going to work. Certainly get to the no ROSC patient, you know, you're in ECMO. I think the questions to answer are, is when you're in C&D, what's the utility of Impella versus ECMO? Those trials should be done. They're ongoing right now. Yeah. So I think it helps us.
So if I may add, for example, right now, this whole conceptualization of cardiac arrest survivor with the Glasgow Coma Scale, how of a differentiator it is so empowering. That is the perfect, I think, crux of how it changes the definition of futility versus not, which is not being done, is actionable. So we should probably, rather than trying to, you know, devour the whole thing, start with those practice changing components of this and already wire it. Because I do see a huge utility to incorporate. It's all on the left side. I see that. I see that, you know, the hypoxic brain injury on the left side, but it is not in the armamentarium of the scoring system and or a staging. So what you just said is beautiful. I think is what would be the next probably implementation part of this conceptualization. This conceptualization is wide, maybe. Dan may need to come up with areas where there is truly a necessity for doing certain things, where we have this bifurcation point in a decision-making system, wiring the processes and creating the processes to do them.
Dan, we block you up, so.
Okay.
No, I mean, so I was just thinking back to the very first meeting that we had at SCAI. I think it was at SCAI where this whole thing started, right? David and you and Hari and a bunch of other people. And the thing I'm reminiscing about was, what was the purpose of developing this scoring system? And David really spearheaded it. And David, we had these conversations that the initial intent was to have a way for clinicians to communicate with each other about, you know, I'm transferring you a patient, he's SCAI E, he's SCAI D, C, you know, I'm signing out, I'm doing my morning report, this and that. And I'm not sure that at that moment, for sure, when we were developing this, that people had any concept of how this was going to explode. Yeah. This SCAI stage thing has exploded from day one. It's probably one of the most cited papers from multiple journals. So it kind of has taken on a life of its own and maybe expanded beyond what its original intention was. And the comments, I think your talk really addressed my question to David, because I don't think this could be used to, you know, in clinical trials for randomized. We should discuss this more. because I think you want something that is, when the patient hits the door, that you know where this is going and it's actionable, et cetera. But we know that there are, in line with there are about, over the years, and we wrote a review paper on this, there are about 20 different indexes, scores that say severity of shock. And this is where we still need to revise things. But we have things like the CARD shock score, the IBB2 shock score, we have SOFA, we have, there's like 5 other ones that are pretty probably INOVA score. And these are all pretty useful. Some of them have, some of them don't have the etiology. Some of them require 24 hours. Was there reperfusion? What's the TIMI flow?
I had them in my backup slides, and their prognostication is beautiful too, by the way.
So this, I think, is more what you're getting at, and where I also think that concept is very different than what the SCAI stages were intended to be, and the success has kind of brought SCAI stages to a different place where it was originally intended. That's kind of my perspective on it.
David, what your take here? Because I think we hear in a lot of voices said, we have something that have a life of its own. It's the beginning. We are going to do some adaptation with time, but maybe, and again, I think the simplicity is what makes it so. The graphic and the simplicity.
One more thing. I remember, and I had this conversation with David, I said, what you're talking about is something like the Intermax scores. How simple was the Intermax scores? And how successful was that? And how we use it? We don't use it, for what it wasn't intended to be.
Yeah.
SCAI stages to me is kind of like Intermax.
David?
So I'm going to pile on with what Dan said, which is that, I think that the investigators related to the SCAI development has actually been terrific. It has provided a horizon, and it has provided the ability for us to be able to prognosticate. And by definition, prognosticate means we're not 100% correct. And that we all look a lot smarter looking in the rearview mirror, that we now actually have a horizon to look at. So we have a language to actually talk about. And so I think that what it is, and I think that's really good. Right or wrong, it now provides a language for where it will be a precipice for where we'll actually have actionable items to go forward in terms of operationalizing what we're going to do next. To Dan's point about Intermax, now I think where we're not there with SCAI, and I haven't heard in a room full of experts so far today, is how is it that we're going to define success? SCAI is just a tool in part of this, but we're talking about shock. And so the definition of what success looks like for Intermax, we're actually looking at mortality. We're looking at years past either the intervention for a transplant or ventricular assist device or whatever it is, or none of the above. And so at the end of the day, I think that this is eloquent and does not need to be over dissected. And it's going to evolve with time. Patience and the tincture of time will actually show how apparent and how eloquent this really is. There needs to be a focus now on trials that actually look at operationalizing how we use this language. We'll define it with time, and then we need to be able to define success.
Thank you, and Biykem, thank you for a great talk, and congratulations to Biykem, the new editor of JACC Heart.